Thank you to the organizers for the invitation to present today and the pleasure to talk about our work. And also my apology that due to the local responsibilities in the middle of the academic year, I was not able to attend in person. The most enigmatic aspect of cancer remains the formation of metastases, the spread of cancer cells from their originating tumor through the blood or lymph stream into the body, here in the case of the breast cancer, into the lymph nodes, the bone, and the brain. So we need to do better in terms of diagnosing and treating cancer metastases. We have been working on a molecule called osteopontin that is associated with the progression of multiple cancers, including breast cancer. In a meta-analysis many years ago, we showed that osteopontin is associated with breast cancer, in addition to about 30 other cancers. It is associated with survival, particularly in breast cancer. Here we see the relatively strong number of studies that had already been done so many years ago. This is of interest. Osteopontin is a marker also for the early progression of breast cancer. So these are the patients who have lumps in their breast, but are still at the premalignant stage, that are still not fully developed cancers. And the presence or the occurrence of osteopontin in these patients is actually associated with the further development of breast cancer. So very early on, we learned that osteopontin is a progression marker for multiple cancers, and it is associated with grade stage and early progression, as well as patient survival. So why is osteopontin not in the clinic if it is such a promising marker? There are two problems. The parent molecule that is unmodified actually serves in the body as a cytokine. You see here a study that we did a number of years back that osteopontin is actually an early type 1 inducer cytokine. Here's a standard model of a sterile type 1 response. That's a foreign body granuloma. You see here the injection of PVP into the subcutaneous tissue, and a wild type mouse will form granulomas, and these granulomas consist mostly of T lymphocytes. A mouse that lacks osteopontin, here designated with its immunology name ETA1, forms fewer granulomas, and these granulomas are mostly constituted of macrophages and neutrophils, and that mouse cannot clear the foreign body granuloma. Another problem that was reported by one of the pioneers in the osteopontin field, Ann Chambers, is the multiple post-translational modifications of osteopontin. So when we try to use it in an ELISA format as a diagnostic, depending on where the antibodies bind on the molecule, we see that we can get a wide range of different results. So this is a problem when we want to develop a biomarker. So we learned that essentially immune functions and structural variation compromise the cancer biomarker osteopontin, and we need to find a solution. A number of years back, we reported that osteopontin has a number of variants that are generated by alternative splicing. Here we see the three different forms. Osteopontin A on the top of this block diagram is the longest form. This is our cytokine. This is the one that generates the Th1 responses. Selectively in cancer and only in cancer, we can find variants that are shorter, including osteopontin C and osteopontin B. Now of note, breast cancer makes A and C. It does not make B at all. Other cancers make osteopontin B. So we developed initially only a polyclonal antibody and tested it in immunohistochemistry, and we see that osteopontin C, the splice variant that is cancer-specific, that is totally absent from the normal breast, stains according to increasing grade of the breast tumor. This is a function, a characteristic that the three standard markers, HER2, ER, and PR, do not have. They do not correlate with the grade of the tumor. So we're getting information from osteopontin C that we cannot get from the standard markers. Now, Osteopontin is also associated, or osteopontin C is also associated with the progression of the breast cancer. We see here the classical Kaplan-Meier survival curves and the osteopontin staining intensity. When the staining is low, then the survival is higher. When the staining is higher, then the survival is lower. And that also is the case for exon 4. Exon 4 stains osteopontin A in the breast because we don't have any osteopontin B. So we see that the two splicing forms are prognostic in breast cancer. So we have learned osteopontin C is a marker for tumor grade and for prognosis. And it's more reliable than total osteopontin. So total osteopontin, even though it was also correlated with the prognosis in breast cancer, is not as good as when we focus on these splice variants. Now, that was all promising, but it doesn't do us any good. We need a clinically actionable issue. We need to address something that in the clinic is an important question. And you may remember in one of the earlier slides, I showed you that osteopontin C, pan-osteopontin was associated with the progression of early breast tumors, the pre-malignant lesions. So we were asking, if we now focus in on osteopontin C, can we actually predict which of these lesions will become malignant and which of these lesions will not become malignant? So we obtained a number of lesions that were initially defined as low risk, intermediate risk, and high risk. They all have these long Greco-Latin terms from atypical hyperplasia, papilloma, radial scar, DCIS, LCIS, etc. And we see that actually, first of all, osteopontin staining is associated with the risk that the pathologist ascribes to it. So the high-risk lesions tend to have a higher fraction of samples that stain for osteopontin C. The low-risk lesions, on average, have a lower staining. So the osteopontin C staining is associated with the risk lesion. Now we took all of these lesions with all their Greco-Latin terms and put them together in one pot and said, when we combine them all, are we still able to identify the patients who are at high risk for progressions according to the high staining of osteopontin C? And that was exactly the case. Particularly for osteopontin C, we see that with increasing pathology score, the cancer-free prospect is much reduced. And then when we dichotomize the pathology scores, 0 to 1 is one group, and 2 to 3 is another group, we see that this divergence in terms of recurrence prospect is even widening. Exon 4, which detects osteopontin A and B, of course, we don't have any B in the breast, also has this pattern, but it's not quite as strong as osteopontin C. So we now took these two markers together and devised a risk score. We just combined them into low, intermediate, and high, taking these two together. And what you see on the bottom is recurrence risk of these premalignant lesions. On the top, it's survival. These are the patients who succumbed afterward or did not succumb afterward within 5 years. And we are actually able to predict very reliably what the recurrence risk is, and even more dramatically, what the risk is of dying from cancer for these patients who at the time of diagnosis only had the premalignant lesion. They have no cancer at all. And we are able to prognose who are the patients who are likely to get breast cancer, and among them, who are the ones who are likely to die from breast cancer. And conversely, who have a very low risk for progression and who have a very low risk of dying from breast cancer. And when we look at the numbers, this is actually quite impressive. So we have the correlation with risk. 95% of women who experienced relapse had pathology scores of 2 to 3 for osteopontin C intensity at the time of initial diagnosis. About 10% of the osteopontin C pathology scores of 0 to 1 relapse over 5 years. Now, when we combine these two markers together, all low-intensity patients are alive after 5 years, And the high category patients have now a chance of about 30% to die within 5 years from cancer. Among the patients who succumbed, close to 80% had a high score of osteopontin C at the point in time of diagnosis. So we have learned that osteopontin C is prognostic for transformation risk in these premalignant lesions. This is an area where we need diagnostics and prognostics very badly, and we are in the process of going through the regulatory process in order to get this marker to the patient and enable the treating physician to make much better treatment decisions, who should prophylactically get treated and who can engage in watchful waiting. Now, another urgent problem in the management of breast cancer is the prediction of treatment responses. So here we have hormone therapy, a standard in the ER-positive breast cancers. And we are now looking at the survival curves and stratify them according to osteopontin C, high or low, treated or untreated with tamoxifen, and then exon 4 staining intensity, high or low, and treated or untreated with tamoxifen. Now here we see something that at first glance may seem counterintuitive. Osteopontin exon 4, our osteopontin A, which is also the cytokine, is actually associated with a favorable response to tamoxifen treatment. Why is that? Well, actually, osteopontin has a function in breast milk. It is highly calcium binding and therefore prevents the calcification of the breast milk during lactation. In order to achieve that, osteopontin has in its promoter an estrogen-sensitive element, an estrogen response element. So estrogen induces the expression of osteopontin. So the breast cancers who are very estrogen sensitive also produce a lot of osteopontin. And this is the transcription, right? This is not the splicing. That's why we see osteopontin A being the indicator. A breast cancer that is estrogen sensitive has a lot of osteopontin, and that breast cancer will also respond very well to tamoxifen. But transcription is the key factor here. It is not splicing. And now we look at a standard chemotherapy that was the CMF regimen, and we realize immediately that there is quite a gap here between the high staining and low staining patients in terms of their treatment response. And yes, indeed, here it's our cancer progression marker, osteopontin, that is associated with a poor response. Now we're not dealing with the estrogen sensitivity, we're dealing with regular chemotherapy, and we see here that a high expression of osteopontin, which makes the cancer more aggressive, is also associated with a poor response to chemotherapy, whereas a low abundance of osteopontin makes the cancer less aggressive, and that makes it more responsive to chemotherapy. Now, unfortunately, in this study, we had very limited samples. We looked at patients who had experienced radiation therapy to the chest, and we saw actually a trend here in terms of high osteopontin also being a predictor of poor response to radiation. However, due to the limited number of patients, we did not reach significance here. So we would like to expand this. We're certainly hoping that we can get more patients whom we can study so that we can fully validate osteopontin and maybe also the splice variants in terms of predictors of treatment responses. So we see here osteopontin exon 4 predicts a favorable response to hormone therapy, but a poor response to the CMF chemotherapy regimen. And there's a trend also to predicting a poor response to radiation treatment, but significance was not reached in the study that we completed. So we have osteopontin as a very promising prognostic and as a very promising predictor for treatment responses. Now, we know that osteopontin splice variant C in particular is actually associated with the aggressiveness of the tumor. This is a molecule that is functionally important in cancer progression. So now the question is, can we use the anti-osteopontin C antibody? And by now, of course, we do have monoclonal antibodies, a rapid monoclonal for diagnostics. And we also have our humanized monoclonal that we would like to use in the treatment of cancer. Now here we have a mouse model for treatment. MCF osteopontin C is a transfectant. This is our marker here for abundance of osteopontin. The MDA MB435 cells have gotten a pretty bad reputation because their lineage origin is not clear. However, what we do know is that they are very aggressive cancers, and they are very reliable producers of the osteopontin splice variants. We also used here pancreatic cancer cell line. It has a moderate or modest expression of osteopontin C, but even that is essential in vitro to form metastases. So when we put these cell lines into nude mice and counted lung colonies, both of these cells colonized the lungs. But when we treat it with anti-osteopontin C antibody, we see a dramatic reduction here in terms of the metastases formed by MDA MB435 cells. And we do see also a total disappearance of the metastases from the BXPC3 cells. So there's a lot of promise. We are in an early stage. This is all a validation stage. We are hoping to move that forward. We would like to expand the mouse models and then, of course, develop the antibody in what we call the IND-enabling studies, the studies that enable us to get approval from the FDA for the use in clinical trials and move forward with this. So we now have anti-osteopontin C with a potential as a therapeutic in an anti-metastasis treatment, and we want to develop that further. We've now spent well over 25 years researching osteopontin in cancer progression. We've now spent well over 20 years working on the osteopontin splice variants. So at this point in time, we have learned that spliced OPN may inform on cancer type, progression, and survival prospects. In breast cancer, osteopontin A and C are of prognostic value for the premalignant lesions. The monoclonal antibodies to osteopontin C and exon 4 are in testing as diagnostics, and we are hoping that we would have them in clinical use within a year or no later than 2. And we are working on developing the humanized antibody as a therapeutic, and we are hoping to find better mouse models, stronger mouse models, and we are raising the funds in order to get the IND-enabling studies going. So it has taken a long time, but we are in a situation where we have a lot of progress and a lot of hope for the path forward. Metastases are still undertreated, and it is urgent time that we overcome the situation and do something about this. Thank you very much.